Hi everyone. I want us today to look at antibiotics. These are drugs that are used in the management of bacterial infection and they are commonly prescribed. So what are the key points in this particular presentation? We want to know what an antibiotic is. We shall classify antibiotics. We will look at their uses, their misuse, resistance, possible side effects, and characteristics of ideal antibiotics. So how do we define antibiotics? This is a substance. Antibiotics are drugs. They are drugs which can be naturally occurring, can be semi-synthetic or synthetic. So they destroy or inhibit growth of microorganisms, in this case bacteria. So antibiotics from this definition, they work in two ways. That is through destroying the bacteria or inhibiting the growth of a bacteria. Here is a diagram. We'll just show some examples of antibiotics. From a distance you can see this looks like amoxicillin. So these are just various types of antibiotics. We have categories of antimicrobial therapy against stages of disease progression in this diagram here. The antibiotics, when they are used to prevent an infection, that category of therapy is known as prophylaxis. The antibiotics, when they are used to treat an infection which has not developed symptoms, that category of therapy is known as preemptive. Antibiotics, when they are used to treat an infection which the patient has developed symptoms, this category of therapy is known as empirical. So that will be empirical management. That is when a patient has infection and he has symptoms as well. Antibiotics, when they are used after the test has been done and the pathogen has been isolated, that type of therapy is known as definitive management. Then we also have another category, that is when the patient has completed treatment but he still has got some few bacteria that they have not cleared completely. When given medication for resolution, that is what we refer to as suppressive category of antimicrobial therapy. This is just a repetition of definition. We said antibiotics can be obtained from microorganisms. They can also be synthesized and they destroy bacteria in two ways, that is killing and also inhibiting growth. Generally, drugs are produced from plants, animals, minerals. Some are synthesized, others obtained from microbiological organisms together with genetic engineering. So those are just sources, general sources of drugs in general. So what are the sources of antibiotics? It can be natural or it can be synthetic. It can also be as well as semi-synthetic. When antibiotics are obtained naturally, then they can come from fungi or bacteria. When they come from fungi, examples we have penicillins and chrysophalvin. But remember, chrysophalvin is an antifungal, so it has just been included there as an example of drugs that come from fungi. So it's not an antibiotic. When antibiotics come from bacteria, particularly from the Bacillus species, then example can include polymyxin, pacitrazine, among others. And when antibiotics are obtained from bacteria, particularly on actinomycete species, then examples of such antibiotics can be tetracycline, chloramphenicol, and streptomycin. When they are obtained synthetically, examples you can have mofloxacin, as well as norfloxacin. So these two are examples of synthetically produced antibiotics. Okay, these are repetition of the sources of antibiotics we have already mentioned. We said natural sources, which can be from fungal, and we gave examples. Here we have another example, gentamicin. You have those that can be synthesized semi-synthetically. Example is ampicillin and amikacin. We have those that can be synthesized fully from artificial laboratory techniques. Then example we have moxifloxacin and norfloxacin. That's just a repetition of what we had already mentioned. So how do we classify antibiotics? There are 5 ways. You can base on mechanism of action, this one here. You can also base the classification on the type of action, the chemical structure, type of effect, as well as the spectrum. When we classify antibiotics based on antimicrobial activity, then we have 2, bactericidal and bacterostatics. Bactericidal, these ones kill the bacteria, while bacteriostatics, from the word static, these ones they inhibit growth of a bacteria. Remember we said antibiotics work basically in 2 ways, either to kill or to inhibit growth. When they inhibit the growth of a bacteria, then your immune system gets a chance to destroy the bacteria. So that is when we classify antibiotics based on the antimicrobial activity. When we classify them based on spectrum, then we can have narrow spectrum, broad spectrum, and we have another one here, what we refer to as extended spectrum. So this is spectrum, extended spectrum. So remember, bacteria can be grouped into 2 major groups, and that is gram-positive and gram-negative. So gram-positive and gram-negative antibiotics are bacteria. We have drugs that act on gram-positive bacteria and gram-negative bacteria. So if you have antibiotics which act on gram-positives only, then that is an example of a narrow spectrum. And when you have antibiotics which are on gram-negative only, that is also a narrow spectrum. But when you have antibiotics which act on both this and this, then that is what we call broad spectrum. And when you have antibiotics which act on either of these only, which is a narrow spectrum, and then it is modified. Then it's modified so that it can be able to cover the other category of bacteria. Now that is what we call extended spectrum. Extended spectrum. So what we are saying is, for example, if you have bacteria's antibiotic that is active on gram-positives only, it can be modified such that it can be able to also kill some gram-negatives. That is now what we refer to as extended spectrum. Example of some ways of doing this procedure of extending the spectrum of antibiotics, you can have something like amoxicillin, which is normally combined with clavulanic acid to give you amoxiclav. So this one becomes an example of extended spectrum antibiotics. So that is when we group antibiotics based on the spectrum of activity. Antibiotics can also be classified according to absorbability, and that is locally acting and systemic. Examples of locally acting here, we have things like eye drops, you have things like creams, you can have ointments, you can even have sprays. When examples of those that are given systemically, we have mostly injectables. So that is when we classify antibiotics based on absorbability. You can also classify antibiotics according to their mechanism of action. We have those inhibit bacterial cell wall, those that inhibit the cell membrane of a bacteria. We have those that inhibit protein synthesis, and we have those that inhibit nucleic acid synthesis. We shall see. So this diagram can help us to explain the various modes of action of different classes of antibiotics. For example, if we take cell wall synthesis, those antibiotics that act on bacteria through inhibiting cell wall synthesis, they normally use what we call a beta lactam ring. This ring resembles that one that is used in the synthesis of the cell wall of a bacteria. So what normally happens, this class of antibiotics normally incorporate this ring into the framework of the cell wall of a bacteria, which now makes the cell wall weak and non-viable. The cell wall being made weak and non-viable, the bacteria's contents are usually exposed, and therefore the bacteria dies. So examples of these drugs that act on the cell wall synthesis include penicillins, cephalosporids, carbapenems, and monobactams. Very common example of carbapenems is meropenem. This one is a very broad spectrum, powerful cell wall inhibitor, and it works very well when it is given to bacteria that are sensitive to it. It's a very good antibiotic. Something you need to remember also about this category of drugs, we have other bacteria that are very stubborn. So they produce an enzyme called beta-lactamase. Beta-lactamase, which inhibits this ring on the antibiotic, therefore rendering that antibiotic weak and non-responsive. So the manufacturers of antibiotics, after realizing this scenario, now they added a molecule. They decided adding molecules in these antibiotics. A good example of that molecule is clavulanic acid. Clavulanic acid, which is normally added to something like amoxicillin to give you amoxiclav. So the amoxicillin will give you the beta-lactam ring, while the clavulanic acid will give you, will inhibit the beta-lactamase enzyme. Therefore, the drug becomes very, very strong against that bacteria. That is how the manufacturers of antibiotics counter this challenge of beta-lactamase enzyme. So let's look at another category, and that is those that act on the cell membrane. Example, we have polymyxin. These ones, they normally just interfere. They interfere with the cell membrane of the bacteria. Therefore, the cell membrane also become weak and leaky. So it becomes leaky. The contents leak out and the bacteria just dies. Then we have another category of antibiotics which act by inhibiting protein synthesis. And these ones work on the ribosome. They work on an organelle known as ribosome. Remember, this organelle is the one that is used in the manufacturing of proteins in a bacteria and even in human beings. So what normally happens, the structure of this ribosome is known as, the structure is actually the 70s, but now it has subunits. It has 50 subunits, then it also have 30 subunits. So what normally happens is we have these antibiotics that bind on the 50 subunits of these ribosomes, and therefore rendering this ribosome unable. They make it unable to bind the messenger RNA. Remember, messenger RNA has information from DNA which is supposed to be used by the ribosome to produce proteins. So if I bring an antibiotic to block here, then it means this ribosome will not be able to encode information from messenger RNA, and therefore that process will stop, and therefore the bacteria becomes halted. Remember, the bacteria cannot grow if protein production has been stopped. Example of antibiotics which stop the 50s subunits is the macrolides. Macrolides, example here, we have what we refer to as clindamycin. We also have something like the linezolid. Linezolid also works at this point. Also, we also have azithromycin in this category. Then those that bind on the fatty subunits of the bacteria, example, we have tetracycline. Another example is aminoglycoside. Remember what happens here is almost similar to what happens here, but here now we are using the transfer RNA. Transfer RNA is the one that has brought amino acids, is the one that brings amino acids. Remember, amino acids are the basic structures of proteins. So for the ribosome to produce proteins, it needs amino acids. And what brings these amino acids to the ribosome is the transfer RNA. So when I bring my antibiotics and block this route here, then the transfer RNA will not be able to be binded on the ribosomes, and therefore this organelle will not be able to produce proteins, and therefore it will, its growth will be halted. So that is basically how that category of antibiotics work. We have others that stop the DNA gyrase. DNA gyrase is an enzyme which is used to introduce what we refer to as negative supercoils. Remember, DNA is a double helix strand. It has two strands, one and one, that are intercoiled together. So, for DNA to give information to messenger RNA, this double helix strand must open for this messenger RNA to be able to copy information from this strand, the information which is needed by the ribosomes to encode and produce specific proteins. So the enzyme that opens this double helix strand is what we refer to as DNA gyrase. DNA gyrase. So we have our antibiotics, which stops this, which blocks this enzyme from opening this strand, Therefore, if this one is not opened, then our messenger RNA will not be able to pick information from this DNA strand. And therefore, it means the bacteria will not be able to survive. Example of these antibiotics which blocks DNA gyrase, we have quinolones. Example of quinolones is a broad-spectrum quinolone, commonly known as ciprofloxacin. We have also others that work by blocking RNA polymerase. RNA polymerase is also an enzyme. Its function is to join nucleotides. Remember, these are the molecules that form DNA. So we join nucleotide plus nucleotide plus nucleotide to get a DNA strand. The enzyme that joins these nucleotides is known as RNA polymerase, particularly for messenger RNA. So if we give you antibiotics which blocks this enzyme, which is known as RNA polymerase, then it means that enzyme will not be able to join these nucleotides to form DNA, meaning that bacteria will not be able to survive. An example of antibiotics which works by stopping DNA polymerase is rifampicin. This is an example of those antibiotics that works in that category. Another category of antibiotics are those that interfere with the metabolic pathway of a bacteria. So bacteria produce folic acid. They synthesize folic acid, which they use in the manufacture of DNA, the nucleotides. Remember, human beings, we don't synthesize folic acid. We obtain folic acid from diet. But for bacteria, they have to synthesize their own folic acid, which they again use in the metabolic processes such as synthesis of DNA. So we have antibiotics which block this pathway. For example, there is a precursor that is used in the formation of folic acid molecules, which we call PABA. So this molecule is a precursor for the formation of folic acid. So what happens is our antibiotics bring in another PABA, which is artificial. So when artificial PABA is incorporated in this pathway, then the process is altered. The process of production of folic acid is altered because this antibiotic has brought a false PABA in this process. Example of these drugs that work here are sulfonamides, as well as trimethoprim. So here we have what we call cotrimoxazole, which is commonly known as Septrin. So this is an example of antibiotics which work by stopping the production of folic acid. This slide is a repetition of the classification of antibiotics, now including several examples in every category, but we had already talked about it. This is now a comparison of pharmacokinetics and pharmacodynamics. Pharmacokinetics is basically what the body can do to the drug, and this includes absorption. So when you take a drug, the drug must be absorbed. It must be absorbed, what we call absorption. After absorption, it has to be distributed. It has to be distributed in the body. After distribution, it has to undergo metabolism, because here now it has finished its function. After metabolism, this drug is supposed to be excreted, because after it has finished its work, it has to be eliminated from the body. So this is what we call pharmacokinetics, what the body does to that drug. And then pharmacodynamics is basically what the drug does to the body. We have a few definition of terms here. There is half-life, and that is basically the time which is required for a quantity of a drug to be reduced to a half of its initial value. Different drugs have different half-lives. And this explains why some drugs are given once daily, others are given twice daily, others are given thrice daily, and so forth and so forth. A drug that is given once daily, it has a long half-life. A drug that is given twice daily has a shorter half-life compared to this one. And this one has a shorter half-life compared to this one and also compared to this one. And then we have something called therapeutic index. This is a measure of the relative safety of a drug. Some drugs have narrow therapeutic index, others have a broader or wide therapeutic index. Drugs that have narrow therapeutic index need close monitoring because the window is very narrow, while those that have broad therapeutic index, they are very safe. Example of drugs that have a broad therapeutic index are cephalosporins, and even penicillins. That's why they are mostly prescribed. First-pass metabolism is the metabolic degradation of a drug by the liver before it reaches systemic circulation. For example, if you take an oral antibiotic, it will undergo some metabolism in the stomach first before it gets into the circulation. So that metabolism that takes place in the stomach or the site of administration is what we are referring to as first-pass metabolism. Then we have the issue of bioavailability. This is just the percentage of the concentration of a drug that has reached our circulation. Remember, when you administer a drug from the site of administration, let's say if you are giving intramuscular or even orally, it has to get absorbed and get into circulation so as to produce its effects. So this fraction of the drug that will be able to reach our circulation unchanged is what we call bioavailability. So if you have a drug that has 100% bioavailability, then it means your drug, the whole of it can be able to access circulation unchanged, and it's a good drug for that case. Potency is the amount of drug which is required to produce a given effect. If I use two examples here, let's say drug A, which is 50 milligrams, can produce an effect in terms of treatment. And then drug B, which is 200 milligrams, can produce the same effect. Then I can say that drug A is more potent than drug B because drug A, we just need 50 milligrams only, while drug B, we need 200 milligrams. That's the difference between, that's the meaning of potency. Efficacy is the maximum effect a drug can produce. This one doesn't depend on the dose. Then you have two terms here, dose and dosage. They are different. A dose is a specific amount of a drug which you administer at one time. For example, nifedipine 20 milligrams, if I give you one tablet to take, that is dose. But if I give you, let's say, amoxicillin, and I'm giving you 625 milligrams BD for 5 days. Now this becomes dosage because it is able to show you the amount of the drug, It is also able to show you the frequency of which you are going to take that medication. It also shows you time of how long that medication is supposed to be used. So that's the difference between dose and dosage. We have regimen. Regimen is almost the same as dosage because it also shows the dose, frequency, and the duration of medication. When it comes to loading dose, it's a single or few quickly repeated doses which we give in the beginning of treatment to target the concentration. And after that, now we go to maintenance dose, which is now repeated at specified intervals to maintain the concentration and balance the elimination. Excipients are just additives that are added in drugs for the reason of maybe patient acceptability. For example, flavors. We have other drugs that are added flavors, particularly for children, so that the children can take. So these excipients have non-therapeutic effect. They just make the drug maybe acceptable to the patient, or they just improve the stability and delivery of that drug. We have factors which influence successful treatment of an infection, and one of them is site, concentration, post-defense, and sensitivity. So the drug must reach the site of infection if you want to treat that infection successfully. 2, you must ensure that you attain adequate concentration. Number 3, at least the patient should have better defense mechanism. Because if you have a better defense mechanism, then just few doses of antibiotics and your body is able to counter the bacteria effectively. Then number 4, the bacteria must be sensitive to this antibiotic for you to succeed. We have a few problems which arise when using antibiotics, and one of them is toxicity. Toxicity can be local or systemic. When it is local, then it is at the site of administration. For example, if we are giving you oral medication, then you can present with nausea, and even vomiting. That is one of the issues. You can also have pain. Pain, for example, if you are being given injection, which is intramuscular, sometimes you may feel pain, particularly, for example, if I'm giving you ceftriaxone, IM, you may feel some pain at the site of injection. Sometimes you also get abscess formation as well as thrombophlebitis. Thrombophlebitis is inflammation of veins. This one occurs when medication is given IV. IV is intravenous IV. IV means intravenous. So those are some of the challenges that occur locally. Systemically, we can have an issue arising due to narrow therapeutic index. Drugs with lower therapeutic index must be individualized, and the toxicity must be watched carefully. Example of these drugs is aminoglycosides, tetracycline, and chloramphenicol. They have a very narrow therapeutic index, meaning you have to balance the dosage strictly. Aminoglycosides and small overlap in their dosages damages the cranial nerve number 8, which is connected to the sense of hearing. So these patients get what we call ototoxicity. They also affect the kidneys. For tetracycline, an overlap in their dosages can damage the liver and the kidney. For chloramphenicol, we normally get what we call bone marrow depression. There's a note here. We have other antibiotics which have very, very low therapeutic index. And these ones, they are not just used anyhowly. They are only picked when all other antibiotics have been exhausted and the bacteria is non-responsive. Because these drugs, they have very, very narrow therapeutic index. A slight increase in dosage will give you problems. So that's why we are saying these drugs, their use is highly restricted to conditions where suitable alternatives are not available. And therefore, the example is polymyxin B. These are very effective antibiotics which works on the bacterial cell membrane, this one. But it has a very, very narrow therapeutic index. Any small overlap will give you neurological problems as well as renal issues. Vancomycin the same, amphotericin B also the same. Another problem that we encounter when using antibiotics is hypersensitivity. This is where patients are allergic to antibiotics. Sometimes it's unpredictable. You can't know until a patient uses the antibiotic. That is when you can know this patient is allergic to this medication. Another issue is drug resistance. This one can be natural or acquired and even cross. When it is natural, then it means this bacteria has never responded to this antibiotic. But when it is acquired resistance, it means this bacteria initially was responsive, was sensitive to that antibiotic, but along the way it has developed resistance. When it comes to cross resistance, it means the drug, the bacteria can be resistant to some chemically related antibiotics. Example is penicillins, as well as cephalosporins. These drugs are chemically related, and therefore you can have a bacteria that is resistant to both. That is what we call cross resistance. So how do we prevent resistance? One, you must select antibiotics. You must use antibiotics only when necessary. Two, you must select appropriate antibiotic. Three, you must prescribe correct dose and duration of treatment. Three, combination should be used to delay development of resistance, like in TB is just tuberculosis. We normally use combined therapy so that to stop the bacteria from developing resistance. These are just part of the reasons why we do combined therapy. And we said one is to obtain synergy. Synergy means drug A plus drug B will support each other to give you a combined effect, which is a good effect. Sometimes we also combine drugs in mixed infections. The commonest mixed infections are found intra-abdominally, in the brain, and also in genitourinary areas. We also use combined therapy when we want to initiate treatment for severe infections, and we want to cover both gram-positives and gram-negative bacteria. That is in what we call empirical management. Empirical. Here, the patient has presented with a severe infection, in which the bacteria has not been isolated. It has not been isolated yet. So you can use combined therapy to cover for both gram-positive and gram-negative bacteria. Another possible scenario where you can use combined therapy is to prevent emergency of resistance, we have said, and also to reduce adverse effects. When two drugs are combined, the dosages might be lower and therefore reducing side effects. We have an issue to do with misuse of antibiotics. For example, in faulty practices where antibiotics are used to treat viral. And remember, antibiotics are not sensitive to viruses, So if you use antibiotic to treat viruses, that is a misuse. You can also have misuse when you are giving too low doses, very low doses. Sometimes when you prolong treatment for no apparent reason, that can also amount to misuse. Also, when you use antibiotics in every fever case, which is probably not due to infection. Sometimes our antibiotics can fail in treatment of a certain bacterial infection. So how do we monitor this? We normally give patients what we call TCA, which just means to come again, When these patients come again, we look at symptoms. We also look at signs, as well as vital signs. So we compare these things with how he presented on the first day. Then we can tell if they are improving or not. So that is what we are calling measuring this failure or probable monitoring through clinical checkup. You can also monitor that through laboratory checkups. For example, when the patient came, we did a test called full hemogram. You start this patient on medication. After day 3 or 4, you repeat the full hemogram. This one will tell you, you compare the results here and results here to tell where you are heading to in terms of management of that patient. But when you suspect there is apparent failure, then you must review your diagnosis. You must also review therapy. Sometimes what we call compliance. Sometimes some patients might not be very compliant to medication. Those are some of the things that can cause failure. So we can say failure can be due to improper selection of the drug and dosages, as well as route of administration together with duration of treatment. So also when you treat your treatment too late, it can also expose you to possible antibiotic failure. When there is poor host defense mechanism, when the infecting bacteria are behind barriers. So what does this one mean, behind barriers? Let's use an example of BBP in the brain. This is blood-brain barrier. That is blood-brain barrier. So what does this mean? It means our circulation is here, and maybe our brain is here. Remember, our antibiotic is circulating in this circulation, and our infection is here. So this antibiotic is supposed to cross, and there's a barrier here. This antibiotic is supposed to cross and get into the brain so that it can manage that infection. But because of this barrier, this antibiotic cannot cross. That's why we're saying when the infection is behind a barrier, like for this case, infection is behind the barrier. Therefore, our antibiotic may not get there. Another example of structures that have barriers is the eye. The same thing. We also have barriers in the eye, which can also do the same thing. So how do we make combinations of drugs when we want to treat infections? We said we have 3 possible outcomes. That is synergy. Can also get antagonistics or no change. So when you combine drug A plus drug B, then there are three outcomes. One, you can get synergism, and number two, you can get antagonism. Number three, you can have no change at all, no change. Therefore, when you are combining your drugs, you must make sure that you get this synergism. This is why you get A plus B combined to give you a better outcome, meaning A is assisting B. But in antagonism, it means A and B are antagonistic. They are opposing each other. Therefore, you will not succeed. Sometimes you can add A and B in some combinations and there is no change. So this one is meant to help you understand that when you want to combine these antibiotics, what do you want to achieve? What is the possible outcome? So one of the things here is when you are combining bacteriostatic and bactericidal. These combinations sometimes may not work because bacteriostatics antagonize bactericidal. For example, if you are giving amoxicillin together with azithromycin, if you get one is bacteriostatic, another one is bactericidal, then it means this will just inhibit this. Therefore, you may not get good results. So before combining antibiotics, you've got to know, is this a bactericidal or is it a bacteriostatic, and so on and so forth. There is something called probiotics. Probiotics are drugs. These drugs, they contain normal flora. Normal flora are bacteria which are found in the human body, particularly on the surfaces or even in the intestines. They are helpful. We call them normal flora. So these bacteria are found in the gastrointestinal tract, and their function, mostly they assist in the production of vitamins. Example of these vitamins is vitamin B, as well as vitamin K, When you have diarrhea, then there are high chances that you will lose a lot of your normal flora. Therefore, that is why these patients, we give them probiotics. Probiotics examples include enterogermina and floranol. These ones are the commonest ones. So, some of the normal floras